Hi, this is Chapter 1, Foundations of Psychiatric Mental Health and Nursing. These are the key terms that are available in your textbook. They are not the same key terms that you're going to have to define when you have your first unit exam, but they are good to know while you're reading the chapter to make it a little bit easier on you. These are the chapter learning objectives. Again, these are found in your textbook. These are the nursing concepts for this chapter. If you were to care for a patient with a mental health illness, these are some nursing concepts that you might apply to their care. So when we start, we first want to talk about mental health and what it is. And we know that mental health is difficult to define because there's no one single universal definition to it. And as the world views and society changes, so does what we consider to be mentally healthy and mentally unhealthy. Although there are some mental health illnesses that have been defined throughout time, the overall definition of it is what continues to change. The factors that influence it can be personal, relationship, and also your environment. I always like to use the example of my older sibling who originally lived in New Jersey, and New Jersey's threshold for mental health crisis is much different than what Vegas's mental health crisis is. So depending on where he is in the country, is how quickly he might end up needing mental health crisis intervention. When we talk about mental illness, it includes, how it affects our mood, our behavior, our thinking. Things like depression, schizophrenia, anxiety, and addictive disorders all impact those. Mental health disorders often cause significant distress and impairment in both your functioning as well as your behaviors and your thinking. Individuals experience dissatisfaction with self, relationships, and ineffective coping. Daily life can seem overwhelming and even unbearable. Individuals may believe that their situation is hopeless. Many factors can contribute to our mental illness. We can have biological, our genetic makeup. All of this can affect our ability to cope. Our family and support systems can aid in our coping, and they can also push us over the edge. Some people are just naturally hardy, where their coping factors are continuous and they don't seem to run out. Other people have very limited coping factors, so they fall victim more rapidly. We also know that social and cultural elements can play a role, as well as our social detriments, which would be our ability to access healthcare, education, money, and our environment, like our neighborhood and our community resources. The DSM-5 is the thing that healthcare providers use to diagnose patients. It's not something that a student nurse uses, but it can be helpful when looking at resources. The newest edition is 2022. It's published by the American Psychological Association. And it helps to provide standardized naming of the illnesses. It uses the appropriate language for all mental health professionals. It gives defining characteristics and symptoms of specific diagnoses, and it also helps providers to identify possible underlying causes of disorders. The DSM-5 classification system allows the practitioner to identify all the factors that relate to the person's condition. All major psychiatric disorders such as depression, schizophrenia, anxiety, and substance abuse disorders are some examples of that. Medical conditions that are potentially relevant to the understanding and managing of the person's medical disorder, which we'll get into that more when we get into different disorders. And also the psychosocial and environmental problems that may affect the diagnosis, treatment, prognosis of the mental disorder. Included are problems with primary support groups, the social environment, education, occupational, housing, economics, access to healthcare, and the legal system. So this is a question. that's true or false. Is the definition of mental health standardized and universally accepted? And the answer to this is false. The rationale is there is no single universal definition of mental health, which has many components and is influenced by many factors. Going through the historical, before Christ, ancient times believed that sickness was a punishment from God or for persons' sins and things that they've done wrong. Many mentally ill patients would be considered possessed. Aristotle was the one who believed that we needed to have a balance in our body of blood, water, um, yellow, which would be your urine, and black, which would be bile. And this led to some bloodletting. Patients would sometimes die because of such a loss of blood. They also would starve people or they would make them purge. When we went into our Christian views, we had kind of a regression where we were going back to possessions and exorcisms. And they would actually place the mentally ill in dungeons. They would flog them. They would starve them. They would do all sorts of things to get the demons out. In 1546, we had St. Mary of Bethlehem's, which was a hospital for the insane. In our period of enlightenment, this is when we were enlightened with the concerns for the mentally ill. England started developing asylums. Asylums were seen as a safe refuge to protect the mentally ill from being beaten, whipped, and starved. Dorothea Dix is the one who brought this crusade to America. She was instrumental in opening over 32 hospitals for the mentally ill. Her goal was to advocate for these patients. She wanted to shelter them, give them food, keep them warm, and she wanted to care for the mentally ill. There is documentation and information about Dorothea Dix that she herself had suffered from some mental illnesses. She had gone to England and had a stay in the asylum, and it was such a positive experience that she wanted to bring it back to America. And then as the asylums started to become overpopulated, I believe she only wanted like 250 patients to each asylum. And by the end of the Civil War, some of the asylums were at 10 times their capacity. A lot of these asylums started doing experimental treatments with patients. Things like lobotomies were developed. Sigmund Freud did a lot of his studies and treatments for the mental illnesses. One famous lobotomy was Kennedy's sibling. He had a sister who was developmentally delayed, and the family was getting worried because they were concerned that she was going to get pregnant. So they did a lobotomy on her. She ended up becoming unable to walk and mute afterwards. So a lot of interesting things had happened during this time period. And one thing that we have to remember that when all of these things were happening, everybody truly thought that they were doing the best thing that they could to treat and care for these mentally ill patients. The lobotomy was thought that by severing the frontal lobe of the brain to the rest of the brain, that the patient would have better outcomes. Some lobotomies were very successful. Lobotomies were more common in women than in men. And then in the 1950s, we started developing medications. Thorazine was one of the first antipsychotic medications that came into practice. Thorazine was originally developed for patients with nausea, and by providers being very in tune and astute to the effects of it, they noticed that it had a very good calming effect, and they considered it to be a chemical lobotomy. So with the development of these psychotropic drugs, a lot of these asylums were slowly vacated by patients who they thought would never be able to leave. And then Kennedy took over as president, and although his stay was very short, he actually signed in to deinstitutionalize asylums, which meant close them down. And he wanted to move towards community mental health movement, which provided states with money to care for their mentally ill. However, states really didn't have to spend the money on that. They could spend the money on anything they want. And a lot of the community mental health movements they wanted to do fell short for caring for these people. At the height of the institutions, which is around 1955, it said that there was over 500,000 people that were living in these institutions, which given the average population of what the country had, that was very significant. So what's our current mental health state? The current mental health state, according to the National Institutes of Mental Health, in 2021, which was really 2019 when the data was collected, we had 51.5 million adults in the United States that had mental health illnesses. And one thing that we need to realize is that the majority of people that have mental illnesses do not necessarily seek treatments. So we consider that number to most likely be lower than what it is. Only 1 in 4 adults and 1 in 5 adults. I'm sorry, only 1 in 4 adults and 1 in 5 children actually get treatment. When we talk about the revolving door effect, this is because of our hospital stays are shorter. So patients are coming in, they're getting treatment, they're getting stabilized, but they're not getting the best treatment. Then they're being shipped out and then they come back. So this is a revolving door. We know that the deinstitutionalization reduced the number of public hospital beds by about 80%. The number of admission to those beds actually has increased by 90%. So again, this revolving door is shorter stays with more often visits. Clients are often being boarded or kept in the emergency room while they're waiting to see or be placed. This places a frustration on healthcare professionals because of their holding these patients that they know they can't appropriately care for while they're waiting for the care that they need. It also creates a dissatisfaction for the clients who need the care as well as their family, and placing that negative stigma on both factors, right? The people that need the care kind of get a negative aspect of it, and the people that are providing or working in those emergency rooms are frustrated. So it also has led to increased risk in our suicide population. And then your book also talks about homelessness. Homelessness, I've recently found out, has over 25 different definitions. And you really need to define what their homelessness is. Are they truly living out on the streets, or are they couch surfing? Do they have a home, but they just don't want to go to it? But we know that many people with mental illness actually end up on the streets, which contributes to this vicious cycle. So another question we have is, which statement best reflects the current state of mental health and mental illness? Is it A, mental health care costs exceed the costs for cancer care? B, most adults and children receive adequate mental health care? C, community resources for the homeless with mental illness are adequate? Or D, deinstitutionalization has reduced the revolving door effect? And the correct answer is A. Mental health care costs exceeds the cost for cancer care. The economic burden of mental illness exceeds all of that of cancer. Objectives for the future. So Healthy People 2030 is just a revision from Healthy People 2020, which was a revision of 2010, which was a revision of 2000. And the aim is always just to make people healthier. We're focusing now on reducing suicide rates and making sure that everybody who needs the services can get the services. And I have the full list on this slide here, which is available on page 5 in your book. So moving forward, we are going to discuss community-based care. Since the deinstitutionalization of the asylum, care for mental health population is kind of ignored, and it's definitely underserved by most communities. A lot of recent documentaries talk about the biggest community resource for these patients is prison, because that's where they continually end up as. All community-based programs have been developed in an aim to meet the needs of the community they serve. However, it just always seems to come up unbalanced. But when they are working, they are usually very positive and they make meaningful impacts. Some examples of them would be mobile MAP programs. MAP stands for medication assisted treatments. These mobile ones are kind of buses that go into communities, and they help patients get the medications they need to maintain their drug regimen, especially if you have a big homeless population and they might not have the ability to get to a pharmacy, or they might not have the ability to keep their meds safely stored. Other examples of these would be our crisis services, our peer supports. Locally, CARM has housing and they provide safe havens. So again, there's many flaws in these. However, they are considered preferable to being in overrun asylums where patients weren't getting always the best care. Our cost containment and management of care. Again, we want to provide quality care, but it also needs to be cost effective. In the 70s and 80s, healthcare costs started spiraling out of control because there was little regulations of services. In the 90s, your health maintenance organizations, also known as your HMOs, got together and they developed managed care, which means that prior to giving services, we need to seek approval. These mental health care is very costly. They require frequent visits, and even one hospital stay can cost tens of thousands of dollars. Many mental health facilities are privately owned, and they don't always take patients that do not have insurance or patients that are on financial aid, such as Medicare and Medicaid. Medicare covers people that are 65 years and older. Medicaid are those on Social Security or Social Security disability insurance. That would be SSI or SSDI until they reach 65 and they can flip over to Medicare. And what happens is a patient might come into the emergency room and they will have to stay in the emergency room until one of the state beds is available. And then private insurance companies can sometimes place caps on the amount of money that's spent in 1 year, as well as caps as the amount of time that a patient can have inpatient therapy. So Peninsula only has so many beds set aside for patients that are uninsured or for patients that are state or federally insured. Some cultural considerations. Chapter 7 is big on your cultural considerations, but as nurses, we need to be aware that not all cultural practices accept or believe in mental health the same way that we do. Some culturals still believe that mental health is demonic possession. Some just do not believe that it exists at all. Since the divorce rate in the United States is greater than 50%, many families are becoming more and more culturally diverse. So it's important that, we don't stereotype or prejudice, and we make sure that we get the right history so that we know what cultural considerations we need to have. True or false? A community-based program is preferred for treating many people with mental illness. And this is true. Again, there are many flaws in the system, but we feel that the community-based programs have positive aspects that make them preferable for treating the masses with mental health issues. Psychiatric nursing practice. So in 1873, Linda Richards was the first American psychiatric nurse. She believed that the mentally sick should be at least they need to be cared for as well as those that are physically sick. The first training for nurses with mental illness The first training for nurses to work with the mentally ill was in 1882 in Massachusetts. The care was primarily custodial, and it focused on things like nutrition, hygiene, and activity. Nurses adapted medical surgical principles to clients with psychiatric disorders and treated them with kindness. The role of the psychiatric nurse has expanded throughout these years. And we've done a lot of different things for them. In 1935, we had the psychological surgeries. 1936, we did our ECT therapy. 1937, more medical surgical skills were used more intensively. Our first text was in 1920, nursing mental disease. John Hopkins was the first school for nursing to include psychiatry in the nursing course. And in 1950, the National League of Nursing started requiring schools to include psychiatric nursing in it. Two early theorists that shaped mental health nursing practice is Hildegard and June. Hildegard was therapeutic relationships, which we'll talk about therapeutic relationships in some other lectures, as well as our interpersonal skills. June focused more on the patient and the patient's strengths and needs and how we can focus on the here and now when we're caring for them. The American Nurses Association has the standards of care, which we know the standards of care are not legally binding, but if we get into a legal problem, they are going to measure us against those. The American Psychiatric Nurses Association also has standards of care for the professional practice for the mental health caring nurse. These also outline the areas of practice. And there's also the phenomenon of concern for today's psychiatric mental health nurse. The phenomenon of concern describes 13 areas of concern that the mental health nurse focuses on when caring. And I have these in this slide right here, which I know it's small to read on the Zoom lecture, but they're available on page 8 in your textbook. These are the nursing areas of practice. Your basic functions would be that of what an associate degree nurse would do. She might help a patient get to counseling, provide milieu therapy, help with some self-care activities, health teaching, case management, health promotion, and maintenance. If you were going to go into the advanced practice nurse, that's when you're going to be doing drug management, program development, and clinical supervision. Student concerns. This is a slide that we could spend hours talking about. I think it's important to know that, you're never going to say something that might completely fix a patient, nor would you say something that will completely end their world. You could say something that could upset them, but you just need to be able to refocus and continue on. We always want to make sure that we're safe. So in clinical, you'll talk about some physical safety things, how to handle bizarre behaviors, how to appropriately ask questions and things like that. We also need to be self-aware, and we'll talk about more of this in the chapters to come, but we need to remember that we need to know our own beliefs, our own viewpoints, our own biases so that we can adequately care for patients. We need to do a lot of self-awareness and self-reflection. We need to be aware of conflicts that might develop and how we'll handle those as they come up. And know that everyone is unique. Everybody has different views and values and beliefs, and we just need to be cognizant of those and support those. That's the end of this lecture. These last slides is the key points of your chapter, which you can find on page 11. Thank you. Have a good day.